Hello, my name is Devorah Overbay. Welcome to Providence Regional Medical Center, Everett. We are a 500-plus bed Level 2 trauma center. Providence Regional Medical Center in Everett was created from a merger between Providence Hospital and General Hospital Medical Center. Providence Hospital first opened in 1905. In 2008, to better reflect its role in the area, the hospital changed its name to Providence Regional Medical Center, Everett. To this day, both campuses resulting from the merger are still in operation. General Hospital as the Colby campus and Providence Hospital as the Pacific campus. PRMCE is one of a handful of Level 2 trauma centers in Washington State. It currently has the busiest emergency room in the northwestern U.S. The first U.S. case of COVID-19, part of the 2019-2020 coronavirus outbreak, was identified in a patient at Providence Regional Medical Center on January 20th, 2020. The intention of this learning event is to introduce you to PRMCE's Executive Nursing and Medical Leadership Team, to briefly describe our shared governance model, and to inform of our communication and safety model. The following physicians are our medical center's medical staff leaders. Dr. Jay Cook acts as the Chief Medical Officer. Dr. Barry Kahn is the President of the Medical Board. Dr. Sarah Hansen is the President-elect, and Dr. Cliff Rogers is the past President. Dr. Matt Beecroft is the Secretary-Treasurer, and Dr. Kim Costas is a Credentials Chair. And Dr. Chuck Daly is the Medical Staff Quality Review Committee Chairperson. The division chiefs include Dr. Mahesh Mulamudi, Dr. Mark Pappenhausen, Dr. Kevin Clay, and Dr. Larry Nikolov. Our nursing leadership includes Kim Williams, our Chief Executive Officer, Janine Holbrook, our Chief Nursing Officer, Tony Booker, the Regional Director of Perioperative and Interventional Services, Dr. Will Parrish, Director of Education, Professional Practice and Research, Dana Kiles, the Director for Acute Care Services, Tammy Allen, Regional Director of Women's and Children's Services, and Julie Zarn, Regional Director of Emergency and Critical Care Services, and Janet Thomas, Director of Medical Education, Safety, and High Reliability. Nursing governance ensures that nurses have a voice in how nursing care is delivered. What is the value of having shared governance? It allows staff an opportunity to collaborate with leadership in determining nursing practice, standards, and patient family-centered quality of care. Our nursing governance is organized in a council structure. Unit-level practice councils, or UPCs, are a great way to become involved. Facility-wide councils are an opportunity for various staff members from across units and disciplines to work on issues together. Nursing Congress is held quarterly and is required attendance once a year. Nursing governance councils and leadership reports quarterly to the whole staff at Nursing Congress. How can you get involved? Join your unit practice council, or volunteer for a committee or subcommittee, or submit an issue to Nursing Governance on the Nursing Governance intranet page. To support evidence-informed practice, we have a dedicated team of clinical nurse specialists and clinical educators. Collaboration with our Providence St. Joseph Health System colleagues improves quality and value of care, and ongoing continuing professional development offerings give practicing nurses room to grow. To promote continued professional growth, we have ongoing professional development offerings, tuition reimbursement through Human Resources, and University of Providence is an opportunity to continue your BSN or MSN or even the doctorate. Certification assistance programs are available, as are contractual education funds through your collective bargaining agreement. Nursing peer case review is another important component to nursing staff involvement in quality care. It is the process by which participating or practicing registered nurses systematically access, monitor, and make judgment about the quality of nursing care provided by peers as measured against professional standards of practice. The primary focus is the quality of nursing practice with cost in mind. Some of the questions we ask include, were there adequate tools, policy, education available for the nurse to make the right decision and do the right thing for the patient according to professional standards and the best outcomes for the patient in the most cost-efficient way? Beside participating in nursing governance and in quality improvement, nurses at PRMCE work to communicate well in order to provide safe care. In this next section, we will describe tools used to communicate clearly, discuss how and when to utilize the chain of command, and describe the role of rapid response teams and the cardiac monitoring unit. In an environment where healthcare professionals care reliably, we are compassionate, safe, and reliable. We are building our patient experience of safety, quality, and satisfaction. High reliability is competent people working together to provide safe and effective care. We have a common language. Some problems that contribute to errors include workload fluctuations, interruptions, fatigue, poor handoff, ineffective communication, not following protocol, and fixation on an outcome. Culture of high reliability requires caring and helps prevent the same problems from occurring in the future. At Providence St. Joseph Health Systems, we have come to embrace a culture of high reliability. The tools that encompass this culture are when members pay attention to detail, communicate clearly, have a questioning attitude, operate as a team, and speak up for safety. The first universal behavior and tool is communicate clearly, which includes using SBAR, repeat back, read back, and phonetic clarification. Inadequate communication in the hospital can lead to adverse events for the patient. Good communication, on the other hand, is an essential part of providing our patients a safe and caring environment. To further describe some of those communication tools, SBAR stands for Situation, Background, Assessment, and Recommendation, and can be a method to communicate a problem or a situation for which you have a request or recommendation. CUS stands for I am concerned, uncomfortable, stop. Is a very useful communication tool when a staff person is uncomfortable and needs something to stop. We use the phonetic alphabet to reduce confusion over sound-alike letters like D and C, M and N, etc. Use A as in apple or B as in Bravo. For numeric clarification, say 1, 5 for 15, or that's 0.9. Mistakes are most often made when care of a patient is transferred from one provider to another. It is very important that caregivers use tools for handover communication. At PRMCE, we have the following tools. We use bedside report, and it involves the patient and family. It allows the nurse to introduce the caregiver on the oncoming shift. Professional exchange report serves as a handoff tool, and it'll be covered in the EPIC classes later. A ticket to ride is a real-time printed report for staff who will temporarily care for that patient. Ticket to ride needs to be current. Hourly purposeful rounds decrease patient anxiety and builds patients' confidence and trust. It improves interdepartmental teamwork, decreases call light usage, it improves staff satisfaction, saves steps for nursing, and improves clinical outcomes. Purposeful rounds are performed hourly between the hours of 0600 and 2200, and every 2 hours during the nighttime hours of 2200 to 0600. We offer the bathroom to the patient regularly. We proactively take the patient to the bathroom at least every 4 hours. Make sure the patient is comfortable in their current position. Check on the patient's pain level and make sure everything is within reach and the area around the bed is safe. Hourly rounds, RN to MD rounds, and leadership rounds are on the patient satisfaction surveys. RN to MD rounds helps with continuity and allows all members of the team to hear the same information. Leadership rounds are nurse managers, supervisors, or charge nurses talking to patients and families. It is important to confirm understanding. Teach back is when the nurse asks the learner to repeat in their own words what they need to know or do. Repeat back is useful oral communication when precise detail must be communicated as well as meaning. Read back is required by hospital policy for telephone orders and critical labs. Teaching patients and family begins at time of admission. It is helpful to teach throughout the stay and not wait until day of or day before discharge. It includes, but is not limited to, discharge planning. Consider patient factors that impact decision-making capacity and learning. To further communication, every patient room has a whiteboard communication board. They should be updated every shift and as needed as changes occur. It helps patients engage in their care and can provide easy access to important information for patients and families. Beside communication with patients and families, it is important to understand chain of command. When an issue is unresolved, chain of command structure can facilitate resolution. It's equally important to begin with a discussion with the involved person, whether it be a peer, staff, or provider. Rapid Response Team, formerly known as ASAP or Assist Staff and Assess Patients, responds to calls, assisting staff, and assessing the patient and facilitate care. They're available on the Colby and Pacific campus. The team consists of a critical care nurse, respiratory therapist. Spiritual care comes for family-activated rapid response calls. It provides 24/7 coverage. We dial 66 to call for the rapid response team. We use approved nurse-initiated orders. The rapid response team nurse can help you identify other assessments or interventions needed for your patient. They can help create an SBAR before contacting the MD. They'll review telemetry, labs, and other diagnostic tests. Most calls are placed by the primary nurse. Doctors and charge nurses also place the calls. Families are given access to the rapid response team, but very few calls are initiated by concerned family members. The phone number is on the wall, and inpatient writes books given on admission. A rapid response call can be made when a person is worried about the patient or when there's an acute change in the heart rate, the systolic blood pressure, respiratory rate, O2 saturation, change in mental status, stroke symptoms, suspected seizure activity, sepsis screen, or for chest pain. Finally, cardiac monitoring unit is staffed by a critical care nurse and a trained ECG tech 24/7. CMU staff monitor telemetry information from inpatient telemetry units, excluding the critical care and the emergency department. The CCU nurse in the CMU monitors EPIC programs created to notify staff of a change in patient condition and to identify septic patients. Cardiac monitoring unit staff will notify staff nurses when the telemetry monitoring is compromised, like when the batteries need to be changed or if the leads are off. A patient has not been put back on the monitor after being off the monitor for a reasonable amount of time, for instance, for a test or procedure. And they'll call for changes in a rhythm that need to be brought to the attention of the staff nurse. The purpose of the CMU is to provide alerts when a patient's condition has changed to the point that they require immediate assessment and possible interventions. The goal is to decrease unplanned critical care transfers and code blues on the medical surgical units. Well, that concludes this portion of the general nursing orientation. It is hoped that after this learning event, you're able to state 3 goals used to communicate clearly, to discuss how and when to utilize the chain of command, to be able to describe one situation in which you would use a handover tool, to identify one situation when you might call rapid response team and describe the role of the CMU. In addition, it is hoped you are able to describe PRMCE's executive nursing and medical leadership team, and also to discuss our shared governance model. If you have any questions, please reach out to Nursing Education or your assigned unit supervisor.